Thank you for watching the final part of the ESCP Safe Anastomosis program in colorectal surgery training for site principal investigators. Here we will discuss how EAGLE will assess the impact of the ESCP Safe Anastomosis intervention across several hundred sites worldwide. If the ESCP Safe Anastomosis intervention is demonstrated to be beneficial for patients in this study, it will transform care in operating theatres around the world. The primary objective of the EAGLE study is to determine whether the ESCP safe anastomosis intervention leads to a clinically relevant overall reduction in anastomotic leak rate following right colectomy and ileocecal resection. We will also look at a number of secondary outcomes, including mortality, wound infection and stoma rates, and we will determine the effect on anastomotic leak in predefined subgroups of patients, such as those undergoing emergency surgery. We will also demonstrate whether a new trial methodology called a dogleg design is effective for assessing complex interventions, such as surgical change in practice. The inclusion criteria for EAGLE are designed to mirror those within the ESCP 2015 audit of right colectomy and ileocecal resection. They are deliberately pragmatic so as to include as many patients as possible undergoing this type of surgery and have the broadest impact and highest chance of patient benefit. In terms of patient inclusion, both elective and emergency operations are included. Right colectomy or ileocecal resection are both eligible, as long as they are not performed as part of a more extensive resection, such as a pan-proctor colectomy. Operations where there is a second procedure, such as a small bowel stricturoplasty or small bowel resection with a second anastomosis, would not be included under our protocolized definitions. Importantly, patients undergoing both right colectomy or ileocecal resection are included whether or not they undergo primary anastomosis. So if the patient undergoes formation of a stoma rather than anastomosis, they are still included within the study. Any indication for surgery is eligible and from any approach, whether that be open, laparoscopic, or robotic. In terms of centre eligibility, no volume or size restrictions have been imposed. From the ESCP 2015 audit, we estimate that a median centre would input 5 cases per month during the study window. In this section, we will take you through how EAGLE study setup and delivery may work in a typical centre. You are currently in the site enrolment period, where you have expressed your interest in being involved in the EAGLE study, and you are getting set up with your site registration. You will require to complete a number of site administrative forms in order to be accepted for randomization. This may include ethics, audit, or institutional research board approval at your centre, regionally or nationally, depending on your country's specific laws. Once the correct approval is in place, you will enter the notification period, where you will wait for your randomized sequence allocation and the timing to collect data at your centre. Once you have received your allocated data collection window, you would begin baseline recruitment to the EAGLE study, including all patients undergoing right colectomy or ileocecal resection at your centre for a period of 2 months. After 2 months, we'll begin the training and implementation period for the ESCP safe anastomosis intervention. How to train and implement participants at your setting will be covered separately in a future module. However, this may include meetings specifically for surgeons, site staff, and anaesthetists, and ensuring that all surgeons and trainees undertaking right colectomy at your centre complete the online training module, which should take no longer than 1 to 2 hours to complete. After completing and implementing the ESCP safe anastomosis intervention, you would collect data on patients undergoing right colectomy for a further 2-month period. This means in total, data collection at most would last up to 4 months, with a month in the middle for implementation. You will see on the next slide that this is the maximum possible time frame for the study. One of the most exciting things about the EAGLE study is its trial design. EAGLE uses a new trial design which has never been tested in an evaluation of a complex intervention such as surgery before. This is called a dogleg design and was published by Hooper et al. In 2014. This design ensures that every centre has the opportunity to be exposed to the study intervention, whilst completing the study in the shortest time period possible. By making a comparison between centres rather than before and after at the same centre, it ensures that the trial design is as efficient as possible, with as few as patients as necessary included in order to make a meaningful conclusion. For you as an investigator within the EAGLE study, you will be given a time frame to collect data. You may be asked to implement the quality improvement intervention at the beginning of your data collection period. For example, you see here randomization sequence number 1, where the implementation comes first, and then you will collect data after. You will not therefore need to enter before data onto our REDCap server. If you are randomized to sequence number 2, you will begin by collecting before data. You will then have a month to implement the study quality improvement intervention, and you will then collect data after implementation of the EAGLE safe anastomosis intervention. Finally, if you are in randomization sequence number 3, you will collect data before implementing the quality improvement intervention, and you will not need to upload data after implementation of this at your centre. In this way, comparisons between centres, but not within centre, will be made. Therefore, comparisons are contemporaneous and at low risk of bias. The outcome measures for the EAGLE study mirror a number of those seen in previous ESCP cohort studies and audits. The primary outcome measure for the EAGLE study will be the reduction in the overall anastomotic leak rate, and this will be defined by the ESCP's consensus composite outcome measure, either as gross clinical or radiological evidence of leak requiring surgical or radiological intervention, or the presence of an intraperitoneal, being abdominal or pelvic fluid collection on postoperative imaging. The study is designed to be powered to an 8.1% baseline rate in this primary outcome measure. The secondary outcome measures for the EAGLE study include postoperative mortality up to 30 days, postoperative morbidity, classified by the Clavin-Dindo complication grade, the overall length of stay in hospital, and we will also measure the absolute and change in rate of stomal formation, be that diverting ileostomy above an anastomosis or defunctioning ileostomy without an anastomosis. We will also be undertaking a parallel process evaluation to see how change is made within the study and what effect this has on patient outcomes. The sample size calculation for the EAGLE study is based on data from the 2015 ESCP audit. In order to detect a clinically meaningful reduction in anastomotic leak rate from 8.1 to 5.6%, that's a relative risk reduction of 30%. We will require 333 hospitals with 4,440 patients in total to obtain an 80% power at a 5% level of significance. We need your help in achieving this to make a benefit for our patients. Importantly, the EAGLE study will use a single corporate authorship model. This has been used successfully by a number of other international collaborating groups, including the ESCP Cohort Studies and Audits Committee. All contributors will be listed as PubMed citable collaborators, which they can search via the PubMed search bar. In this way, we recognise the absolute contributions that people make to this project while sharing credit and responsibility for the outputs. Thank you very much for watching this presentation on the EAGLE study and a simple run-through of its protocol. We would be delighted to have your participation in the study and answer any questions you might have about the study protocol, which can be found below. We look forward to delivering this study with you and transforming care around right colectomy for the benefit of our patients.